So this is the cancer-associated thrombosis, updated treatment algorithm, and more presentation. We can go to the next slide. So this presentation is brought to you by the Scientific Planning Committee, which included 7 members, including Mark Curr, Normand Blais, me, Alison Bond, Mary D. Carlis, Eddie Lang, Hannah Stracy, and Howard Stewart. Next slide. So my name is Alison Bond. I am a pharmacist at Sunnybrook Health Sciences Center here in Toronto, Ontario. I do have some disclosures. I have previous relationships with Bayer and Thrombosis Canada, both receiving honoraria from them. Next slide. This program has received unrestricted educational grants from Bayer, Leo Pharma, Pfizer, and Servier, but the program has not received in-kind support. And we can go to the next slide. And of course, this program has been developed by the Planning Committee and has been peer reviewed. All recommendations involving clinical medicine are based on evidence that is accepted within the profession. All scientific research referred to, reported to, or used in the program to support or justify patient care recommendations conforms to generally accepted standards. Next slide. This program has also been accredited by both the College of Family Physicians of Canada and the Royal College, and is eligible for 2.25 main pro plus credits, or a maximum of 2.25 hours. Next slide. For the agenda, Norman will start us off with what's new in the update. I will then go over DOACs and drug-drug interactions. And finally, Norman will finish us off with a case on secondary prophylaxis in patients with cancer before we go into our Q&A component. This learning program has 3 objectives, and by the end of this program, participants will be able to 1, discuss updated elements in the 2021 treatment algorithm in cancer-associated thrombosis, updated Canadian expert consensus. 2, describe and discuss areas of clinical uncertainty. And 3, apply the updated treatment algorithm to patients in your practice. Next slide. And I will now let Norman take it away and give himself a quick little introduction before getting started.
So thank you very much, Alison. As you can read my disclosure slide, I'm trained in medical oncology and hematology. I had some interest early in my career into hemostasis, so that led me to go to McMaster's to do a master's degree in medical science, specifically in hemostasis, and my practice evolved to chair the lung cancer program at the Schim Cancer Center, and I'm still involved in thrombosis research, specifically related to cancer-associated thrombosis. So we can move to the first slide of tonight's program. So I'll be reviewing in the next few slides what we did in this new 2021 update for the management of cancer-associated thrombosis. So we can go to the next slide. So many of us were Canadian hematologists, thrombosis experts, medical oncologists, and the essential work was done to get a multidisciplinary feeling of how to best treat these patients with thrombosis. Next slide. So this is the most important and busiest slide of tonight's presentation. You can see that the algorithm, for those of you who had seen the previous version, has been detailed and changed. So essentially, if we go through this algorithm, you can see that we start with cancer patients that don't have contraindication to anticoagulation. And these patients in themselves present a very unique challenge. But the algorithm mostly is going to look at patients that can be treated. So the first step in the algorithm decision tree is to ask whether this patient is at risk of bleeding, because it is felt that for many patients with high risk of bleeding, low molecular weight heparins might still be preferred as the first strategy to treat these patients. And then when we evaluate the different risks of bleeding, whether it be risk of GI bleeding, risk of mucosal bleeding from treatment-associated toxicity, whether it be thrombocytopenia, intracranial lesions, hepatic impairment, use of antiplatelet agents. There are many different clinical situations that one can feel that there might be a preference for one strategy or another. But as a general statement, the group still felt that there was more experience with low molecular weight heparins in patients with high risk of bleeding. The same thing can be felt about patients with unresected intraluminal, gastrointestinal, and genitourinary cancers. These patients have a higher incidence of bleeding, of course, and with the evidence that was present at that time, we felt again that more evidence showed some security towards low molecular weight heparins. And another potential very important element to consider is the presence of drug-drug interactions. And that's probably one of the most challenging aspects of deciding which treatment to give to a patient with thrombosis, as many agents now that we use to treat cancer have the potential to interact with the DOACs. So close collaboration with the pharmacists, and Alison will discuss this later on. Many situations can now lead us to prefer one treatment over another. Obviously, when there's no risk of bleeding, when there's no drug-drug interactions, many studies now have shown that DOACs can be very successfully used to treat cancer-associated thrombosis. And the last part of the algorithm is to reassess patients on a 3 to 6 month basis to continue to evaluate the risk and benefits of anticoagulation. So we can move to the next slide. Of course, the incidence of cancer-associated thrombosis is increasing over time. For one, the volume of cancer patients are increasing. The number of treatments that we give to these patients have increased. The invasion to the vasculature is also increasing with the use of ports, intravascular devices that also contribute to the risk of thrombosis. Next slide. As such, this study that was published last year showed that the incidence in cancer patients has increased from 1% to 3.4% in 2017, telling us that it's a more important clinical issue now than it was before, and we're still going to see thrombotic issues in our patients for many years to come. Next slide. Obviously, many treatments contribute to this risk. You can see on this slide, for instance, that immunotherapy, kinase inhibitors, chemotherapy, anti-angiogenic therapy all contribute to the risk of thrombosis, making us wonder for certain patients if some prophylactic strategies might be useful. Tonight's program won't touch this, but many studies have addressed this previously. And obviously, when a patient does develop thrombosis on any of these agents, then the algorithm comes into play as to what treatment is best for that particular patient. Next slide. So why should we think about primary prophylactic therapy, as we've discussed? We know that therapeutic anticoagulation is associated with a higher risk of recurrent events and major bleeding, because patients with cancer do have a higher risk of having thrombosis, even though they are adequately treated. And on treatment, they can bleed more often. Recurrent events are associated with a decline in quality of life. So any extra burden to the patient with cancer can increase morbidity and impact his quality of life. Obviously, more treatment leads to more resource utilization and all-cause healthcare costs. And obviously, especially with the use of subcutaneous needles, these patients have another trauma to their distressing situation, and anything to decrease that could be potentially helpful. Next slide. So in the end, when we identify patients with thrombosis, we want to give the right treatment to the right patient to decrease all these potential impacts. Next slide. This slide summarizes the many different trials that we have now to evaluate the potential of different treatments for cancer-associated thrombosis. The earliest trial that was published already 4 years ago compared edoxaban to dalteparin. SELECT-D was a smaller pilot trial that was presented in the same year and published later on, comparing rivaroxaban to dalteparin. 2 trials then showed the advantage of using apixaban compared to dalteparin with different endpoints that we won't have had the time to go into, but we can discuss this in the Q&A session. Caravaggio was the largest trial in that group, once again comparing apixaban to dalteparin. 2 newer trials with the smaller effect size is the Castadiva trial comparing rivaroxaban to dalteparin, and one newcomer to this group is the Canvas trial. That was a very pragmatic trial comparing essentially any DOAC to any low molecular weight heparin, and once again showing some interesting data for all these different drugs. Next slide. So you can see in this slide the outcomes in terms of recurrent VTE, and you can see the very homogeneous effects of these different trials favoring DOACs compared to low molecular weight heparins with a hazard ratio of 0.67, with confidence intervals ranging from 0.52 to 0.85. And in the more than 3,000 patients that were randomized, we see a difference of roughly 2.7% in the incidence of recurrent VTE in the whole population. So a very small but significant difference in the risk of recurrent events with DOACs. Next slide. So the opposite side to this benefit is the risk of major bleeding. And you can see that the difference is quite different from one study to another. Essentially, when we put all these studies together, we show that there is a small increased risk of bleeding with DOACs with a risk ratio of 1.17. The confidence intervals are pretty wide, going from a small benefit to a more marked increase in risk. And this translates to an absolute difference of 0.6% difference. So a very small difference in risk of major bleeding. But once again, as the algorithm suggests, if a patient is felt to be at a bigger risk of bleeding, then potentially there is more harm with DOACs than low molecular weight heparins. If we would go into the details of every study, we would see, for instance, that Adam and Caravaggio suggested a better risk profile for apixaban compared to other drugs. But obviously, no trial has really compared DOACs between each other. So it's really hard to say if that difference is related to methodology or patient population or really an effect of the drug in itself. So next slide. Clinically relevant non-major bleeding once again showed an increased trend to bleeding with DOACs, and we see that in every study with an absolute difference of 3.8%. So once again, suggesting that DOACs potentially have a very small but significant increased risk of relevant bleeds. Next slide. So I'm going to turn over to Alison, who's going to talk about drug-drug interactions.
Okay, so this is a topic that is near and dear to my heart, as I feel like it's something I deal with every day and get asked about all the time. So we can go to the next slide. So at the end of this case, Participants will be able to 1, describe the mechanism of drug-drug interactions with direct oral anticoagulants, the DOACs. 2, identify references to help identify clinically significant drug-drug interactions with DOACs. And 3, create a VTE care plan for a patient with DOAC drug-drug interactions. Next slide. So we're going to start off with a case, Mr. LV. He is a 67-year-old male with prostate cancer and new left leg swelling. He had a left leg Doppler ultrasound that showed an occlusive popliteal to femoral vein thrombosis. His past medical history is significant for hypothyroidism, and his home medications include abiraterone 1,000 milligrams daily, as well as prednisone, levothyroxine, and a multivitamin. Next slide. On examination, he weighs 79 kilograms. His left leg is swollen, but he's able to ambulate with minimal difficulty, and he has no obvious bleeding. His lab results include a normal hemoglobin of 132, platelets of 248, an iron of 1.03, a creatinine of 97 for a creatinine clearance of 73 mils per minute. Next slide. So here's a question for you. Given the medications that Mr. LV is currently taking, what is the most appropriate anticoagulant treatment for him? So this is a poll that the participants may answer. So option A is apixaban, 10 milligrams PO/BID for 7 days, followed by 5 milligrams PO/BID thereafter. B, dalteparin, 15,000 units sub-Q daily. C, dalteparin, 15,000 units sub-Q daily for 5 days, and edoxaban 30 milligrams daily. Or D, dalteparin, 15,000 units sub-Q daily for 5 days, followed by edoxaban 60 milligrams PO daily. Well, I guess you guys are not able to vote. Hosts and panels cannot vote. So, next slide. Okay. So about half of you said D, dalteparin 15,000 units sub-Q daily times 5 days on edoxaban. And the next most popular option was A, apixaban 10 milligrams PO/BID for 7 days, followed by apix 5 milligrams PO/BID thereafter. And so in my opinion, I think A is the most appropriate. There is technically no wrong answer, but I do feel like apixaban is easier. It's oral, which most patients prefer immediately, which is much more convenient. But we'll go over why I don't think there's a drug interaction with the apixaban that would eliminate it being used. So we can go to the next slide. So when faced with drug-drug interactions with DOACs, you want to make sure you have good references to go to and having a good pharmacist to go to. So some of my favorite references include the 2018 European Heart Rhythm Association Practical Guide. I will constantly look up product monographs, both the one available from the manufacturer, as well as a lot of product monographs are available on Cancer Care Ontario with recommendations. And I like to consult primary literature. So I like to consult the protocols for a lot of the RCTs for the DOAC trials in cancer patients. There's also a Thrombosis Canada drug interaction guide, and there's a liver, that we'll go over in a few slides. There's also a University of Liverpool interaction checker with cancer medications, which is also very helpful. But in this particular case, you want to think about abiraterone. So this is a pharmacokinetic drug interaction, meaning that can affect, in a pharmacokinetic drug interaction, either the absorption, distribution, metabolism, or elimination, and in this case, the metabolism. So the European Heart Rhythm Association identifies abiraterone as a moderate inhibitor of CYP3A4 and a strong inhibitor of PGP, and that abiraterone should not be used in combination with a DOAC. The abiraterone product monograph does state that it is a moderate inhibitor of CYP3A4 and has been shown to inhibit an efflux drug transporter in the liver in vitro. The Cancer Care Ontario monograph states that abiraterone is a moderate inhibitor of CYP3A4 in PGP in vitro, but that this interaction may not be clinically significant and says that caution should be used in combination with medications that are substrates of PGP, which includes all of the DOACs. In the Hokusai VTE study, abiraterone was allowed if the dose of edoxaban was dose reduced from 60 milligrams daily to 30 milligrams daily. And in the Caravaggio study, no restriction was stated and on the use of abiraterone with apixaban, meaning that certain patients could be on it or included into the study. Next slide. So when we go back to our algorithm, after considering the risk of bleeding, the type of cancer, we want to think about drug interactions. And when we're thinking about drug interactions with DOACs, if there is no interaction, we can use a DOAC. If there is an interaction, we want to avoid it. How do we decide if there is a drug interaction? It's very good to have a pharmacist on hand to review all of the patient's medications and try to identify medications that are strong inhibitors or inducers of CYP3A4 or PGP that might you might want to avoid the combination of a DOAC with. Next slide. So when we're thinking about these pharmacokinetic drug interactions, it's important to remember that inhibitors of CYP3A4 or PGP can increase drug levels and therefore increase the risk of bleeding, whereas inducers decrease drug levels and increase the risk of VTE. It's also important to note that the severity of these interactions can vary. So some medications can be weak, inhibitors or inducers, whereas others might be moderate or strong. Next slide. So this is just a list of some medications that are considered to be clinically significant drug interactions with DOACs, but it's important to note that some medications are weak inhibitors and others are strong. I would say that anything that is identified as a strong inhibitor, I generally try to avoid. Moderate or weak, it might really depend on the patient's baseline risk of VTE and bleeding and whether or not they're on multiple inhibitors or inducers. Next slide. So this is the Thrombosis Canada drug interaction guide that is available on the website. It's very useful. It's very practical. It includes a number of medications that they would avoid and caution and that are okay with the DOACs, and it separates the DOACs for each one. It's important to note that all of the DOACs are substrates of PGP, but only rivaroxaban and apixaban are really clinically metabolized by CYP3A4. Next slide. So let's just do some what ifs. So what if Mr. LV was on an antifungal? So the most commonly used antifungals are the azoles, and azoles are generally thought of as strong inhibitors of CYP3A4 and PGP. So unfortunately, the answer is it really depends on the antifungal. So of all the antifungals, if they're using fluconazole, fluconazole is actually a moderate inhibitor of CYP3A4, and therefore if somebody is on a short course of fluconazole, my answer would not change. I'm okay with somebody being on any of the DOACs if they're on fluconazole, if it's for a short course. However, if somebody's on a different antifungal or a different azole, then I probably would try to avoid most of the other DOACs, and I would tend to favor using edoxaban at a reduced dose as per the Hokusai VTE cancer protocol. Next slide. What if Mr. LV was on other moderate inhibitors of PGP? Well, next slide. Again, unfortunately, the answer is it depends. So there is some evidence that if a patient is on multiple inhibitors of CYP3A4 or PGP, it can be similar to them being on one strong inhibitor of CYP3A4 or PGP. However, the number of medications that somebody would need to be on to do that is likely different from patient to patient, and their baseline risk is also probably very important. So likely my answer would not change, but again, it really depends. Therefore, it's very important that patients be aware of potential drug interactions and that they should always notify someone if they're starting, stopping, or changing a medication, especially their pharmacist, and that they should monitor for signs of bleeding and VTE. Next slide. So what you really want to take away from this little snippet is that inhibitors of CYP3A4 and PGP can increase DOAC drug levels, theoretically increasing the risk of bleeding. Inducers of CYP3A4 and PGP can decrease DOAC drug levels, theoretically increasing the risk of VTE. Again, these are theoretical. There is no good clinical data showing this. Very limited clinical evidence supporting clinically significant drug interactions with DOACs. And finally, and of course, there may be more than one right answer. So somebody might prefer one thing and somebody might prefer another. Unless a medication is well documented to be a strong CYP3A4 or PGP inhibitor, I think that it's fair to do different things. And it really kind of depends on all the medications involved, the patient characteristics, their baseline risks, and the available evidence. It's very important to have good references to check for up-to-date information. And finally, and very importantly, do not get DOAC drug levels to manage a drug interaction. There isn't data to guide on what to do for that, and you'll kind of just get yourself into trouble. So either make the decision that you're comfortable with the drug-drug interaction, and if you're not, then avoid it. Next slide. And I'll hand it back over to Norman to go over secondary prophylaxis in patients with cancer.
I was muted, so we'll just continue on with the second case. We can move to the next slide. So I'm going to talk about a patient that is a very common patient in my practice. We're going to discuss the indication of secondary prophylaxis in a patient with cancer. We're then going to discuss the importance of multidisciplinary evaluation of any patient with cancer that has had previous thrombosis. And then we will have an open discussion with the patient considering available evidence and knowledge gaps because treatments can vary. We can have many questions afterwards and many different answers for these questions. So we'll start the discussion with the following case. Next slide. So this is a 54-year-old male who is being treated for lung adenocarcinoma, stage 3B. He has a 5 centimeter right upper lobe mass with bilateral paratracheal nodes. His NGS for molecular biomarkers is negative, and he has a very high PD-L1 status of 50%. This patient is a previous smoker, moderate obesity, 110 kilos. He was known for hyperlipidemia, has type 2 diabetes, treated on aspirin for primary prophylaxis. So his medication when I saw this patient was on aspirin 80 and rosuvastatin 10 milligrams daily. Next slide. So for the 3A non-small cell lung cancer, he was treated with concomitant chemoradiation. He received a conventional course of 33 fractions to 66 gray to the tumor with cisplatin and vinblastine as a concomitant chemotherapy. During his treatment, he presented with new onset left-sided chest pain with a pleuritic pattern, suggestive, of course, of pulmonary embolism. He was referred to our clinic for evaluation, and we were able to perform on that same day CTPA. So the CT pulmonary angiography confirmed left-sided main pulmonary artery clot with stable vitals. Many of you might have wondered why he was receiving aspirin. So it was easy for us to discontinue considering the soft indication for aspirin in this patient. And we replaced that with apixaban 10 milligrams BID for 7 days, then 5 milligrams BID for 6 months. And we were all able to do that in one clinic visit or 2 clinic visits on the same day without the patient having to go through emerge or going through a hospitalization, which is pretty nice to see in patients with cancer to avoid the already crowded emergency rooms. So next slide. So his post-chemoradiation evaluation shows improvement in the lymph nodes, in the right upper lobe mass. And we see, as we always do, radiation-induced changes in the radiation field. We were able to still see some filling defect in the left main pulmonary artery. Actually, that was no longer visible, I'm sorry. The patient went on to receive 1 year of durvalumab because we know that this immunotherapy drug is associated with improved disease-free survival and overall survival in that setting. This patient came back to us with intermittent bruising on the upper extremities and occasional epistaxis. And after 6 months of therapy, the patient was bothered by the side effects of the anticoagulation, and it was felt that this patient was in remission and he would be better served by using 2.5 milligrams of apixaban BID for secondary prophylaxis. Next slide. So one very general question with a very long answer is, what is the contribution of cancer, chemotherapy, and immunotherapy to the incidence of thrombosis? Next slide. Well, obviously, this answer is very long because the etiology of thrombosis vary from patient to patient, and that is impacted by the patient features, body size, sex, previous histories, comorbidities. It also varies according to the cancer type. We know that some cancer types like gastric cancer, pancreatic cancer, ovarian cancer, lung cancer, all have increased incidence of thrombosis compared to other tumors like prostate and breast cancer, for 2 examples. So it's important to evaluate all the risk factors and the risk factors for continuing risk of thrombosis when we think about secondary prophylaxis. And the possibility of dose reduction is something that we discuss often in the clinic. You will see that there's no real data to really guide us in that regard, but the added benefit of having reduced side effects by decreasing the dose is a major factor that leads many oncologists to want to do that in their practice. So we will see many patients now that have this dose reduction, even though that the original trials continued the therapeutic dose for the remaining of their cancer journey. Next slide. The next question that we can ask is, what is the evidence to support reduced dose prophylaxis in a patient with cancer? So I already tried to answer this. There is limited phase 2 evidence that shows that this strategy seems safe and effective in some patients. So it's really a question for the physician to evaluate the potential impact of the cancer in the underlying risk to the patient. So obviously a patient that has an active cancer that was associated with a previous thrombosis, it might not be the perfect patient to consider a reduced dose because the major potential trigger for thrombosis is still present. I mean by this the cancer, the underlying cancer. If the patient has had chemotherapy associated with surgery that is long past, maybe in that situation we can feel that the risk is less. If we feel that the patient has been treated with a curative intent and that the cancer has regressed and is in complete remission, then perhaps we can feel that the risk associated with the underlying cancer is less. So everything that I'm saying is to highlight the fact that many patients, every patient is different, and that many different clinical scenarios can lead to potentially different conclusions in terms of the selection of the secondary prophylaxis strategy. But in the end, a very important trial called the Efficacy trial is actually compared continuing treatment with therapeutic doses of apixaban compared to a prophylactic dose of apixaban. So in my practice, that will be a very important study to help me better define which patients need to be treated with therapeutic doses for many years, perhaps, versus patients where a reduced dose can be safer potentially and be still safe in those patients. Next slide. So when should anticoagulation therapy be completely discontinued? in a patient at risk of a recurrence. Next slide. So here again, the same reflection applies. The recurrent risk varies according to different cancer types, stage, treatment received, and many other prognostic factors. So obviously, a stage 1 lung cancer that developed thrombosis after surgery and is felt to be in complete remission with a very low recurrence rate. These patients can typically be treated for a 6-month period and then be completely stopped once we assess that the cancer remains under remission and the patient is doing well without other important risk factors for thrombosis. So in many cases, we need the input of the treating oncologist, the thrombosis specialist, and obviously our expert pharmacist to help decide what best strategy to use when we use different treatments for these patients. As Alison discussed in this patient that was receiving abiraterone. So if we change treatments while we're treating thrombosis, we need to rethink the strategy. So it is important to reevaluate the recurrence risk every 3 to 6 months and determine if our therapy is still appropriate or adequate. Next slide. So what if a patient develops a recurrence at 9 months of durvalumab therapy while he was treated with apixaban 2.5 milligrams BID? So actually, I'm talking about a recurrence of his cancer. So then we might think of using chemotherapy. The one standard treatment that we could give to this patient is carboplatin pemetrexed. We remember that this patient developed thrombosis while he was being treated with chemotherapy. So there might be some questions regarding his actual risk that might be heightened by the fact that he's going to be challenged with chemotherapy again. Next slide. So here again, carboplatin may be perceived to increase the risk of thrombosis, so it might be relevant to reconsider the dose of treatment. There's no evidence that therapeutic doses of anticoagulation provides greater protection than prophylactic therapy, so we're left with a fact-less scenario where we have to make a clinical judgment. So according to our clinical judgment, we can talk to the patient whether increasing the dose or keeping the same dose will be relevant in a situation of changes of therapy. So there's always really a very important clinical judgment in the domain of deciding what to do in the setting of secondary prophylaxis. And this can change with time and with the cancer experience of the patient. Next slide. So the patient develops recurrence of his cancer at 9 months, and a new molecular analysis by ctDNA shows an ALK fusion mutation, and lorlatinib is prescribed. So this is a different scenario. We're not thinking about chemotherapy now. We're talking about potentially using a targeted tyrosine kinase inhibitor. So how do you proceed? So you don't need to read the rest. You just need to call Alison and she'll make the work for you. But what she will do is consider the potential of drug-drug interactions with the cancer tyrosine kinase inhibitors. We know that there is potential P-glycoprotein and CYP3A4 interactions with lorlatinib. So that might be worrisome to the patients. And most patients aren't necessarily worried about their risk of bleeding or thrombosis, but they're very much worried about the risk of this drug that's going to treat their cancer will be potentially less or less effective or more toxic. So that's something to discuss with our pharmacist. In this case, we know that lorlatinib has a potential to interact less with edoxaban, and I'm going to challenge Alison's statement that anti-10A monitoring is something that can be done, but obviously I know how to evaluate dose levels very appropriately. It's something that's being done in Europe on not a regular basis, but for some patients where difficult clinical decisions lead to the potential to either continue an anti-10A agent when the monitoring levels show that it's within the standard ranges. But I do not recommend changing doses based on anti-10A monitoring. It's just a way to feel sure that the patient is receiving the drug and the dose levels are where you would want them to be. So obviously a very controversial statement, but in the North American setting, it's something that we do not do very often. But if you talk to European experts, you might hear that in different talks. Next slide. So in the end, anticoagulation treatment must be individualized for each patient. The knowledge of the cancer journey and the cancer treatments is very important. As such, multidisciplinary management offers the best comprehensive approach to the antithrombotic care, as well to the cancer care. And I think I've overstated this enough. Risk of thrombosis varies during the patient's cancer journey, and frequent reevaluation is a standard in that setting. So thanks a lot for listening to me, and we're ready for questions if you have them. So if you have questions, you can use the chat feature, and we're watching that closely and are ready to answer any questions you may have. So I might have one question for Alison, coming back to that patient with tyrosine kinase inhibitors. You might have that question often in your clinics. And what is the usual patient, what are the usual patient concerns towards either cancer therapy or anticoagulant therapy when they're using combined interacting drugs?
Yeah, I get a lot of questions about the NIBs, and each one has its own kind of interaction. Some have evidence of more affecting CYP3A4 or PGP. Some of them have quite a high risk of bleeding at baseline. Some of them are used for different durations. The person's initial VTE risk is different. So, I mean, it really all depends on the whole picture. Obviously, if we think we can get away with using a DOAC, we try to do it. I do fall onto a doxban a lot of the time. If I am worried, especially about a CYP3A4 interaction. But yeah, so I mean, sometimes you will tell patients that there's this possibility of a drug interaction, but they're so adverse to either low weight heparin, or if you were considering it possibly warfarin, that they're willing to accept it. So it really depends on the patient. It's hard to say. But again, I just always consult my literature to see what the interaction is. And I do fall back onto a doxaban a fair bit.
So I think that's the strategy we use here too. I think our pharmacist is aligned with your opinion.
So I mean, dabigatran is pretty similar to a doxaban in that it doesn't have that CYP3A4, but dabigatran is more renally cleared, and therefore a lot of these patients don't have very good renal function, and it's BID dosing. So I do tend to favor doxaban a lot more. In the protocol, it did have a drug interaction kind of guide on what to do for dose reductions and which medications they would and would not use. So
in the chat, there was a question from Megan about dexamethasone. Do we need to worry about dexamethasone?
Oh, that's a good question. So some references will list dexamethasone. I generally tend to ignore it. I would like you to show me a cancer patient that doesn't get dexamethasone. Almost all of them get it, at least for nausea and vomiting. And if they're getting it for that, they're getting it for a very short duration at reasonable doses. If somebody's put on dexamethasone, they're usually not on it for very long. If somebody's on very high doses of dexamethasone for a very long time, they're probably going to be a very sick patient that you're not going to want to use a DOAC in anyways. And the data for dexamethasone affecting CYP3A4 is really not very great. So I'm totally fine with, I'm not worried about a clinically significant pharmacokinetic drug interaction with dexamethasone.
Probably most patients in the cancer-associated thrombus trials were on dexamethasone.
Oh yeah.
So the no dexamethasone patient would be the outlier.
Yeah, exactly.
The second question I might take, is there any evidence for secondary prophylaxis with low molecular weight heparins beyond 6 months? Actually, there is a lot of registry or prospective cohort trials that have looked at low molecular weight heparins beyond 6 months. Essentially, they all show that there is continued safety and efficacy beyond 6 months. Most of these trials looked at a further 6 months, so that extends to 1 year. But we can probably extrapolate that data to consider that patients that are on low molecular weight heparins continue to have some safety and efficacy beyond that. Essentially, what we see mostly is that the risk of bleeding and thrombosis is most important on the first months, and then it tends to lower a bit with time. So the decision for long-term therapy, in my opinion, is mostly related to the biology of that thrombosis. So the obvious patient with metastatic pancreatic cancer that is still going on with chemotherapy for 2, 3, 4 years, I feel that his risk is very important to have a recurrence without treatment. So these are the obvious patients that we want to treat long-term, compared to my patient who was treated with curative intent that we feel he's in complete remission. We may want to pull back on anticoagulation during the time that he's on remission.
There was a comment that the addition of dexamethasone to that European guide was contentious and that it may have been removed or downgraded in the 2020 version. I'd have to check the 2020 version. I don't recall. I remember thinking they were very similar, but yeah, I'm not worried about dexamethasone. And then could we have stopped DOAC after 6 months for the patient with non-small cell lung cancer presented in our case if no cancer or thrombosis recurrence?
So the answer is yes. All the answers are good, and we could have continued with high dose, with therapeutic doses. We don't have much evidence to continue with prophylactic doses, but that's what we did in this patient, and we can debate that. And we could obviously stop, considering that the patient is cancer-free. So one thing that I know well, because I treat these patients quite a bit, is that their risk of recurrence is very high in the first 2 years. So I am worried that for a patient that I feel the thrombosis was precipitated by the active cancer, that I'm afraid that I'm going to be caught with an event at the same time or even prior to a recurrence of that disease. So when I feel that the risk is significant of recurrence, and when we talk about stage 3 lung cancer, the risk of recurrence is roughly 50%, I tend to think that it's better to continue on with some form of prophylaxis for a little while. And it's all going to depend on the ease of access to these drugs. Some provinces don't have proper funding for these drugs, some do. In Quebec, we have a code for prophylaxis, so that's easier for us to do. But it's going to depend on all different kinds of factors, obviously. But I would say that, yes, we could stop at 6 months.
And then the next question is, although not evidence-based nor studied in clinical trials, what are your thoughts about using the Corona score to risk stratify patients for secondary prophylaxis in those patients who are now off systemic therapy and in remission?
So this is a question that is taking me a little bit off guard, because I don't know of any study that has actually looked at the Corona score to evaluate risk of recurrence. I know that the Corona score is a good score to evaluate the risk of an event in a cancer patient that hasn't had any previous thrombosis. But then I'd have to check if there are some trials that is actually looking at that score to predict recurrence. And I think that the situation of recurrence is so different from one patient to another, one cancer type to another, one cancer subtype to another, one therapy to another, that there's so much complexity in that setting that I'm not sure that the Currant score would actually turn out to be very predictive. I think that a good oncologist can replace the Currant score until we find a better score to really figure out which patients are the highest risk patients and where we should potentially focus our preventive strategies towards.
And then next question is, when are the studies looking at long-term prophylactic doses coming out? What are the key ones in your opinion?
So I already mentioned APICAT. So I checked on the cancer.gov website yesterday and it's still accruing. But from what I heard previously, it's probably at the end of recruitment. So we could probably hope to have some answers in the next coming year. So within 12 months, I would guess. But it's an uneducated guess. I'm not participating in that trial.
So I actually have a question for you, Norman. You mentioned doing anti-10A levels.
Yes.
I'm curious, when you do them, when do you do it? And do you do it more than once? And if you do it more than once, how often do you do them?
So I'm very fortunate to have a lab that is doing it in my center. But I feel, and I'm friends with a few European colleagues that do this regularly. And what they do is that they do a 3 to 4 hour peak and a previous, just prior to dose, a
trough?
A trough level. So, and we know the average levels that we can expect for patients. And every time I do them, I find that the patient is within the range. Mm-hmm. So it's pretty amazing that low weight patients, high weight patients, renal insufficient patients, patients with interactions, they all fall into the usual ranges. So that's pretty satisfying to me. And in a patient where we'd be more worried, you could do it 2 or 3 times. Mm-hmm. But in my experience, it actually reassures everyone. And that's the reason why I would do it, just to find the outlying patient. Sometimes we have a patient that has, had many prior abdominal surgeries and you're worried about absorption. Mm. If you find a 0 level on your trough, then you might think that this potentially might be not as good strategy as no molecular weight heparin, but you'll tell me that you would have guessed that before because you would have looked at his surgeries and you would have told me that you can expect that, but it's nice to document. The biggest challenge I have with drug-drug interactions is the potential to alter the pharmacokinetics of my cancer drug, because then you're worried about side effects, you're worried about efficacy, and my patients are more challenged by that.
So are you worried about the DOACs affecting the cancer levels?
Yes. Yeah. Oh, okay. So if you're using lorlatinib for in my patient example, if the interaction is in the way of lowering lorlatinib levels, then patients won't want that.
Yeah, because the DOACs are substrates, but none of them are inducers or inhibitors. So I mean, sometimes, so this is one thing. Another references will cite interactions because 2 things are substrates of the same thing. I generally tend to consider those interactions negligible or not clinically important. Because the body would compensate and it would tend to increase levels, increase the risk of toxicity, but don't really worry about those.
Yeah, so that's why we need a good pharmacist in our team. And I always ask before, so the thing I do just before doing my prescription to a patient is call my pharmacist and please check this.
I mean, like almost every medication is a substrate of 3A4, so I mean.
Yeah, so I always have nice discussions. And in the end, I think that most patients can still move on to to DOACs.
Oh, can you comment on the drug-drug interaction between DOAC and long-term use of dexamethasone for other chronic medical conditions along with cancer? Oh, I don't know if
you might want to include high-dose prednisone for immune-related adverse events.
Yeah. To be honest, I generally don't worry about them. I mean, I don't worry about it. That's the bottom line. In those patients, there's usually something else going on that I find that might make you worried about using high doses of anticoagulation in them. Or I tend to see a lot of prednisone used in people with GI diseases like Crohn's, and you might want to avoid using DOACs in them depending on what area is being affected. But yeah, I mean, really, when it comes to dexamethasone and prednisone, I really don't worry about a clinically important pharmacokinetic drug interaction.
So I have an indirect answer to that question, and we published a paper last year, my fellows did, about comparing the incidence of thrombosis in patients who received chemotherapy and immunotherapy. And I thought that the time course of thrombotic events would be different. Chemotherapy having more events during the actual chemotherapy, and patients with immunotherapy potentially have more events during the complications of the immunotherapy. And what we found was really striking is that the curves of thrombosis incidence is exactly the same. And it's not related to the treatment, it's related to the cancer, probably. So we didn't find that immunotherapy or chemotherapy behaves differently in terms of the time trends of thrombosis. And we didn't see a peak of thrombotic events during the period of inflammation or prednisone therapy. So it doesn't answer the question, but to me, it tells me that it's not potentially the prednisone use and the inflammation that's related to the need for prednisone is not potentially the biggest driver of thrombosis in these patients.
I've seen a fair number of patients on long tapers of prednisone, DOACs, and things have worked out. So most of the data that I have come across in primary literature on the drug interactions are mostly in vitro data. There is some clinical data, it's not great, but I view it as clinically insignificant.
Dr. Bond and Dr. Blais, thank you very much for your time this evening.
All right, thank you.
It's a great presentation.